I think I will repeat a few of the slides because actually this is the same group of patients with severe resistant epilepsies. However, you didn't hear much about the history. I just included a few slides and a few articles maybe you will be interested in. It is the Sumerian text 2,900 years before Christ mentioning the cannabis use specifically as an anticonvulsant, and it is cited in this very nice paper from Lozano. As you know also, it has been mentioned also in many Arabic papers and in these perfect papers of Dr. Rousseau, how they found in old tombs 2,700 years before Christ the cannabis products. I spent my holidays, well, 10 days in Sicily, in Marsala. In Marsala they have a very famous Marsala wine, which is a kind of Porto. The English were in Marsala and they were out of Porto and they started to produce the wine from the vineyards in Marsala, and it was perfect. So some of the English people, they prefer Marsala wine now than Porto. But however, they have also an archaeological museum where they keep, I think, the oldest ship from the Punic Wars, from the Cartagena. It is 5th century before Christ. And what is even more interesting is that besides the wine and oil they were using as an equipment on the ships, and some olives is at the rest, and some tools they needed for the fishing and so on. They were always having in their equipment also cannabis. So already the Carthaginians, they thought that maybe cannabis can be a very good medicine for different diseases and for different problems that they had. However, in Europe, there was only at the end of the 19th century that it has been introduced as a medicine by Irish Dr. O'Shaughnessy, who studied it in India for a long time. And soon after that it became very popular, not only in England but all over Europe, and it has been included in many of the pharmacopoeias, as well as United Kingdom as United States. And this is the paper of Dr. O'Shaughnessy describing also the anticonvulsant effect of the cannabis. It has been used also by, it was already mentioned today, by Sir John Russell Reynolds, who was a very famous doctor of the Queen Victoria, and he used it for her menstrual cramps, which were unbearable. So it is written. However, it was not a long time when it became the fashion to smoke cannabis. It was called hashish, and it was brought actually by the French. French are always making a bit of problem. It was brought by Napoleon from the Cairo and from other countries, and it became a fashion. And very soon afterwards, you know that then there was this Marijuana Tax Act and so on, so it became prohibited due to this abuse. And it was put in the Schedule 1 classification by US Drug Enforcement Administration, and this is actually also the problem why cannabis, which was used for 4,500 or even 5,000 years, still we don't know the information about dosing, drug interaction, efficacy, safety, because of this simple prohibition act due to this fact of hashish abuse. And it was only in September last year that DAA was classifying cannabidiol only, not the cannabis, in the Schedule 5 medication. So again, this marijuana field research can be boosted again. And to go back to Sir Reynolds, he stated in the Lancet, which was also at that time a very famous journal, he stated that India hemp is the most efficacious treatment for the people, for the adult patients who have epilepsy. And 150 years in the same journal, very famous epileptologist has published this sentence that even after having a lot of different anti-epileptic drugs for the past 20 years, which is really a boom of these anti-epileptic drugs, about a third of the patients, what we already heard many times today, will be completely resistant to medical treatment. And this is a very well-known paper from Kwan and Brody, who showed the response to the first anti-epileptic drug, to the second anti-epileptic drug, and third, and so on. So the response is falling immediately after we start using second drug. So if the two drugs are inefficient, we call it refractory epilepsy. And it is not only the seizures are refractory, but actually it is changing completely the life of these children and the life of the whole family, because what we call it when these seizures are repetitive, we call it encephalopathy. That means that the complete brain is completely changed, and there is severe decline of cognitive and motor abilities, and so on, together with many side effects of the treatment. It is not only that we know today that a lot of these, especially the early epilepsies, are having specific genetic background, where there is also a motor and cognitive decline associated with these genetic types of epilepsy. But it is also, we should admit, our use of anti-epileptic drugs, specifically if we combine different anti-epileptic drugs, that they will pose more and more problems, and they will declining the quality of life. And some of them, we have heard many times today that cannabis and the cannabidiol, usually they will not have severe side effects, and they will be not life-threatening. However, some of the anti-epileptic drugs can be quite life-threatening. And what we also heard today, that when we use it oral, and unfortunately for the time being for small children, and specifically for those children who are handicapped, the oral use is the only one which is possible. They will go through the first pass metabolism in the liver, and this will cause another metabolic changes. And it is quite different when we use it oral, or we use it like spray, or in inhalation. And also we heard that the CYP2C19, the one from the enzyme P45 system of the enzymes, is the one who will, where the cannabidiol will do the inhibition. And this is maybe also a part of the reason why cannabidiol can be quite efficient, because it can also raise the other anti-epileptic drugs, specifically the benzodiazepines, the clobazam, the frisium. However, it is not the main reason, because we know, as it has been shown by Goldstein, that cannabidiol has different ways of how it works. You see that the majority of the anti-epileptic drugs will work as a voltage-gated channels blocker, but cannabis can also work as calcium-gated, potassium-gated, and as GABA inhibitors, and so on. And this is a recent article, but it is shown that the metabolism of THC and cannabidiol can be a bit different, and the most important of this enzymatic system in THC is 2C9, while in cannabidiol is 2C19. And 2C9 is much more strong and has a significant influence of the metabolism of THC, while 2C19 is not so strong. And what happens with this enzyme? The conversion of THC to 11-hydroxy-THC is the one which is the most important, because 11-hydroxy-THC is the one which is making the psychotic and all the other problems. And as we know, there is a polymorphism of this enzyme, and different people will react differently because of this polymorphism on the on taking of THC. And also this is shown in two other papers, that there are a lot of other antiepileptic drugs which can be influenced by CBD or CBD-enriched products. However, the valproic acid and the clobazam are on the top of the influence. And it was shown by this paper that the clobazam can raise even for 60%, so sometimes reducing clobazam for 30% will not be enough, so we should go a little bit, even a little bit lower, specifically when we have patients who will be somnolent and who will have problems with walking. And even the metabolite norclobazam can be raised for 5 times or for 500 times. And this is also a recent paper from December 2018. It has been shown also for the other antiepileptic drugs which are very often used in epilepsy, specifically in childhood epilepsy. All these can be influenced and the level can raise, but not so much as with clobazam. And as it has been noted many times, when we use valproate concomitantly, the liver enzymes can be raised, so we should regularly make the controls of the liver enzymes. A very known person in pediatric epileptology, Emilio Perucca from Italy, in one of his latest papers, he is claiming that now we do have level 1 evidence that adjunctive treatment of the severe epilepsies is improving when we add cannabidiol. However, that maybe there is still some effect if the clobazam is added, but definitely there are specific epileptic syndromes which will be good when we use cannabidiol or cannabis products. And in this latest paper from the beginning of this year, so 14 days back, it was published. They are claiming actually the same, that definitely there are two resistant epileptic syndromes like Dravet syndrome and Lennox-Gastaut syndrome, which respond very well to add-on treatment of cannabidiol. And what is also, and they are also claiming that most probably there is a lot of interaction with other anti-epileptic drugs. And they also, in this paper you will find the dosing, administration and adverse effect of cannabidiol, which is an important part of this. According to our experiences within 4 years, we did write a kind of guidelines or a kind of recommendations for the medical chamber of Slovenia, how to use cannabidiol and cannabis products in Slovenia for pediatric population. However, still we wait for the final approval to be put on the website so that everybody, all the pediatricians, can use it. And also what we heard today many times is that less is more. If we use very low dose, and when we increase them very slowly, the effect will probably be better. And don't forget this bell-shaped effect. That means that whenever you are increasing cannabidiol, you can come to a point where there will be no effect even if you increase the dose very much. It has been nicely shown in this paper by Ruth Galili and the co-authors that when you use cannabidiol as a pure extract, the shape effect will be much more pronounced than if you use cannabidiol enriched extract, which usually in Israel the majority of people are using. And this we also heard about the entourage effect. This is also one of the latest papers. I think Professor Kramer also showed the same results from the same papers, that definitely there are signs that when we use CBD-rich extracts, that means the whole plant extract, the effect will be better. And what is the most important is that the average dose is much lower than when we use the cannabidiol, which means also that this is decreasing the side effects, and the improvement was better when they used CBD-rich extracts with a very high statistical significance. And of course, cannabidiol, THC alone cannot be used. There should be always a kind of combination, a ratio of cannabidiol and THC, because the psychotropic and subjective severe physical effects can be diminished when we mix THC with CBD. This was also shown today, that until 2013 we have only anecdotal reports of the use of cannabidiol in epilepsy, especially in children. There were no reports. However, after this editorial by the three quite famous editors of Epilepsia, which is the main paper for epileptic or for epileptologists, the use of cannabidiol became much more popular, and especially by this report of GW Pharma, where they have found very nice results that at least 50% of the frequency of the seizures was found in 48%, and 15% were seizure-free. And what followed also, that in the larger cohorts and a little bit older children, it was also very successful and very effective. So today we have studies for Dravet syndrome and Lennox-Gastaut, which are double-blind, placebo-controlled studies, as they should be, to have a level 1 evidence. And there are also some other studies which the results will be published soon. Specifically, this one is very interesting, using cannabidiol for neonatal hypoxic ischemic encephalopathy, because it has been shown on many preclinical studies that the cannabidiol can have very good neuroprotective actions. So this will be the first study. I think it will be published within 1 month. Then when we add to therapeutic hypothermia in newborns, the cannabidiol, the survival and the quality of life of these newborns will be much better. This is how we started. We started in January 2015. We were first we got the ethical approval from our national ethical committee. I think it was at the end of 2013. Yes. 13, yes. And then we also had this ethical principles or ethical position of Epilepsy Foundation, and even of the Helsinki Declaration Act 37, which is saying that whenever you use specific treatments which is not proven in patients who are severely sick and need a kind of alleviation, it can be used. First, we did a small study, and we had 15 children taking pure 1 molecular cannabidiol, and we were comparing them to 12 children for whom we knew that they were taking artisanal cannabis, that means homemade cannabis, and it has been analyzed in the laboratories in Canada. You see, these were the ratios of artisanal cannabis, while the pure CBD was at that time from Bionorica. And the results, the first results, were actually very similar one to another. And this is Paul Hornby from Canada. He was kind enough to do the first analysis of this artisanal cannabis, and the ratio approximately it was around 14 to 1. And these are the results which were very similar to cannabidiol. This is the ethical approval, and this is our protocol. And for the comparison of our studies, we used this paper, which was published a year before from Zadok, and also Yuri Kramer was one of the co-authors. And these are their results. The more than 50% of the seizures reduction was seen in 52%, and these are some of the side effects. This is our study. It was published in March 2018 using the pure cannabidiol. First it was 70 patients, then they were reduced to 67. This was the starting dose, and this was the target dose considered, and only 2 patients were having higher doses. These are the baseline characteristics. You see, very similar to the Israeli studies. Many of them were having combined antiepileptic drugs, very large numbers of antiepileptic drugs. This was the age, and many of them were having also other kind of treatment. And again, as Professor Kramer showed for his study, the majority of them, they had severe epilepsies, so-called epileptic encephalopathies of different structural, encephalitic, chromosomal etiology, and some of them were genetics. And these are the results. There were seizure-free, and improvement was seen in this percentage, and the reduction, more than 50% reduction, was seen in a little bit lower number of children than in the Israeli study. See, this is the Israeli study, and this is our results. These are the side effects. Whenever we reached the dose of 20 milligram per kg, there was some, let us say, quite moderate side effects. The patient was floppy, adynamic, and once we gave the dose of 1,000 milligrams per day, Professor Kramer said that most probably we should not go beyond 800 milligrams per day. One patient looks sedated, and there was some allergic reaction in some, and in one AST and ALT were raised, but however, immediately when we decreased the dose, also the liver enzymes were lower. And on the other side, we have found some beneficial other effects apart from the reducing seizures, and this is the combination of different drugs with CBD. The majority of patients, they had valproic acid and clobazam, but it was not much or significant difference regarding the reduction of the seizures, whatever they were taking. And these are just all the antiepileptic drugs listed, used by our patients. This is just to show one EEG before the use of CBD and after 6 months using CBD. You see that the bursts, the electrical bursts, completely disappeared. This was later in June 2018 shown by a Canadian group who were using 50:1 CBD-THC ratio, and they were counting the spike activity, and the reduction of spike activity on the EEG was 70%. Beside that, there was a statistically significant improvement in quality of life, increase of the seizure-free days, and the decrease of seizure frequency. At the end, just to show some of these systematic reviews, I think Professor Kramer already showed some of them. These are the non-randomized studies with a similar treatment response, and our study is somewhere in the middle of this treatment response. And this is also, once again, how it was mentioned. And of course, we should say that in all the non-randomized studies, there is high potential of bias. In our study, it was unblinded outcome assessment, lack of comparison group, and so on, which is actually the same bias mentioned in all studies which were non-randomized. And there is another one, this one is a little bit larger, systematic review of 14 different articles, and I just wanted to put the facts that already in this systematic review there are 5 studies using CBD enriched cannabis, and there are 3 studies which are randomized, double-blind, and placebo-controlled. These are these 3 studies. There are 3 studies already in children below 1 year of age, and there are 4 studies including adults. This one from Tille et al. Up to the age of 55 years. Artisanal cannabis, it seems that the reduction of the seizures is better, and using the artisanal cannabis or cannabidiol enriched products, it seems that the effect will be better. And what is even more important is that the doses used can be much lower than using the isolated cannabidiol. This is a recent study also from Professor Kramer, where they used CBD enriched medical cannabis, and there was a 50% decrease of seizures and 56%. The dose was around more than 11 milligram per kg, and at the start of the treatment below 10 years of age, the two things together were giving better effect. And what they have found also, that there was no significant differences when they used higher CBD-THC ratio compared to lower, that means in favor of THC. Also, to some extent, we have changed the algorithm today. So today, if there is a resistant epilepsy, resistant to more than 2 anti-epileptic drugs without effect, we use 1 molecule CBD. And if there is no effect with this combination, then we go on add-on of CBD and THC with high ratio. And if there is no effect with the high ratio, then we go on low ratio. Unfortunately, in Slovenia, we do not have natural products. The only available is CBD combined with dronabinol, which is a synthetic THC. And the study with the natural cannabis is still waiting for approval from the Agency of Drugs in Slovenia. In Canada, they already started a very similar study that we want to do at the same time, and they are using the same concentration of 10:1, and this is our study waiting for approval. Today in Slovenia we have two groups who did not respond to cannabidiol. One is using the preparation from USA. They are using so-called Charlotte Web preparation and different ratios of Haley's Hope. They are actually certified products from the States. We know exactly what is the concentration inside. However, which is to some extent a little bit strange, is that there is no proper studies on these two products. I didn't find any study showing the results of this of using these two products. Parents are anecdotally reporting better cognition, behavior, and less seizures, but the proper results we do not have. And the other group which is not using the proper preparations from Heidi's Hope or Charlotte Web is using artisanal cannabis, but we always ask them to bring a small specimen, and we always do the analysis by kind cooperation of Dr. Dusan Žigon, who will have the lecture at the end, from the Institute Josef Stefan, so that we know exactly what kind of treatment we are giving. And also this kind of children, this part of the children, they are describing less seizures and less aggressive behavior. However, we still didn't do the proper results for this group of children. The majority of them, they have different ratios of CBD and THC in these artisanal products. However, there will be also cannabidiol, cannabichromate, and cannabigerol inside. And just to finish, that there are 5 children using CBDA as an add-on to already existing anti-epileptic drugs, plus Heidi's Hope or Charlotte Web, so the two declared cannabis products. And this is the CBDA concentration. You see it is high CBDA, and all the other cannabinoids are very low. And to finish, this is one recent publication from the group of Zaflarsky and Devinsky. It is called Expanded Access Program, and they have now 607 patients, and they were followed up for 96 weeks. And it seems that during this period, that means 2 years, the side effects are mild, and the effect of the drug is quite prolonged. So this is to some extent the proof that cannabidiol can be can have quite a long-lasting effect. These are just some claims from the papers I have shown that today we have compelling evidence that cannabis-based products are effective in the treatment of refractory childhood epilepsies, specifically specific epilepsy syndromes, but what the others are claiming also in other treatment-resistant epileptic seizures. It seems that the results which have been shown on cannabidiol and cannabis or cannabidiol-enriched products, the favor goes to the cannabidiol-rich products and the whole plant extracts. But both the side effects will be mild, and both they will have increase of clobazam, and together with valproate we should be aware that the liver enzyme should be checked from time to time. If we consider 2 years long term, then the long term safety has been shown in the paper, and as it is already stated in some of the papers today, there are some of the products like cannabidiol and TCBDV and CBDV, which can maybe also be effective in future. Thank you very much.
I think you have, Professor, some experience about this developing the tolerance and to make washout period. So maybe how to start the drug and introduce.
Yeah, as Professor Kramer already said, no, we actually, when we reach between 10 to 15 milligram per kg per day, we do not increase the dose, but we very much decrease the dose. Sometimes the children will be left without the treatment for maybe 2, 3, 4 days, and then we increase it again, but with the half dose than we used to use it before. So if before we started with 1 milligram per kg per day, then when we restart with 0.5 milligram per kg. And sometimes it helps, sometimes it doesn't.
Thank you, David, and the group for bringing this issue to this place. I'm disappointed to see a very small number of Slovenian pediatric epileptologists in the hall.
Me too, and even pediatricians are not much.
Thank you anyhow. I would have 2 questions. Remembering the workshop that we had with Emilio Peruca twice when we invited him here to read very carefully the papers, I would have 2 questions. How do you deal with parents who come and ask you to introduce these products to their children, but they do not enter the group that you have been studying? How do you deal with them? If they insist, do you take notice and you analyze the data anyhow? And the second question, the algorithm that you're showing classically would include diagnosing refractory epilepsy as a possible candidate for surgery, which is not there on your slide. I hope that it's still being done. It's still being done. The thing that I would be cautious from another situation, not this one, because I don't have any personal experience in the field now, was that when I'm enthusiastic about a new approach, other classical approaches tend to be neglected. And so how do you deal with that?
Yeah. First, the response to the last question, actually, those patients who were in the study were all not the candidates for the surgery epilepsy, because as you have seen, the majority of them, they had severe epileptic encephalopathies. Either it is a chromosomal one, or maybe this is post-encephalitic, so it is diffuse. They were not candidates for the surgery. So this is the answer to the last question.
Some were also evaluated abroad for epilepsy.
Yes, some of them they were evaluated, and some of them, they, maybe 1 or 2, they were even operated and reoperated, but without any good response. The response to the first question is that when we did the study, somewhere in the middle, maybe, so it was 2016, the mid of 2016, we had to report to the National Ethical Committee what were the interim results. And when we reported about the results, the Ethical Committee sent it to the insurance company, and the insurance company, they decided to finance the product. So at first we started so that the product was bought for the reasons of the study by the University Medical Center, but thereafter it was financed by the insurance. So nowadays, if the patient who can be given cannabidiol can be prescribed on the recipe.
Patients that come to me, they for cannabis, actually I inspect them as coming for evaluation. And if in the end of the evaluation I think that they might be good candidates for surgery, I tell them, listen, my recommendation is epilepsy surgery. But some of the families are answering that, oh yeah, we understand, we're afraid of the surgery, this is not dangerous, cannabis is not a dangerous approach, let us try cannabis first, and then I go with them. CBD and other cannabinoids are lipophilic. We were talking about pretty high doses here. Do you measure the accumulation of CBD in the body, or is that perhaps anything you have to do? Does it have anything to do with the bell-shaped curve? Is that why you have to perhaps decrease the dose?
No, unfortunately in Slovenia nobody can measure the CBD. There is the Forensic Institute. We have contacted them if they would like to, if they will do the studies for us to measure CBD in blood, but they refused because they said it is a quite complicated method. So now when we are planning the second study using the natural product, we are looking forward to do also the pharmacokinetic studies and maybe getting the results of these pharmacokinetic studies will we will be able to do further concentrations in the blood.
The question is about artisanal cannabis from local farmers. First, it's about terminology where this artisanal comes from. You know, it's the first time I hear. Second is what are the forms of these products? What are the forms? Are they herbs, raisins, oils? What kind of forms are these products?
First of all, artisanal. I liked it very much. It is coming from the States now. The Americans are using this word. Actually, this is the local cannabis product or farm product now. Cannabis from the farmers. The other thing is that maybe Dr. Gigon can tell you a little bit more about this, because he is doing the analysis for us regarding the major cannabinoids in this specimen. Unfortunately, yes, we have found maybe in 3 or 4 specimens very high concentrations of THC and very low concentrations of CBD, which should not be. So we in this way we do not recommend them to use such products.